One,
Yeah.
start, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on Metrocon 2024 Outlook. And with immense pleasure, I would like to invite Dr. R.K. Chaudhary, who is Director and Head Medical Oncology, Hemato-Oncology at the Metro Hospital and Cancer Institute, Delhi, and Multi-Specialty Hospital, Noida, for the welcome and introductory note. Over to you, sir.
Thank you all. First of all, I would like to thank you all for joining this 2 days academic feast, namely Metrocon 3. This is an online webinar. We'll be discussing multiple burning topics over the 2 days. Today, we'll be going to discuss about the breast cancer and the lung cancer, and we have the eminent speakers like Dr. Shyam Agarwal, one of the most senior oncologists in Delhi NCR, working with the Gangaram Hospital. There are many other young and dynamic speakers who are going to talk about the various burning topics, specifically immunotherapy coming into the role almost in every malignancy. So we are going to discuss various type of immunotherapy also. So once again, I'll welcome all you. Thank you, and be with us. Participate in the topics and discuss and debate and ask your questions, and we'll be happy to, speakers will be happy to answer all the queries. Thank you so much. So let's start the program.
Sure, sir. Thank you, sir. So for the first talk, and we begin with the session as lung cancer, I would like to invite Dr. Anuradha Chogle, who is Professor in Charge, Medical Oncology, Molecular Laboratory, Tata Memorial Hospital, Mumbai, for her talk on role of biomarker testing in optimal selection of first-line therapy for patients with non-small cell lung cancer. Over to you, ma'am.
Yeah. Good evening, and I would like to thank organizers and Dr. R.K. Chaudhary for giving me this opportunity for the presenters. So my today's topic is on role of biomarkers testing in optimal selection therapy for the patients in lung cancer. So going with the history, like how to proceed with the lung biopsy, principles of molecular and biomarker analysis, we will touch upon a little bit with the tissues involved, how to take the biopsy and what are the role. And however, we are also going to discuss which are the important biomarkers as a first line and which are some of the predictive biomarkers. So evolution of therapy in lung cancer, like it's not a single disease, but many, as you can see over here, over a period of time, like from lung cancer, it has been, it's NSCLC and SCLC. There are several types, like based on the histologic background. And now with the molecular pathology, like it is evolving whether EGFR, ALK, ROS1 are present, and whether they can be either adenocarcinoma or with the EGFR amplification, as you can see, in SCLC. Like, so these are some differentiating biomarkers. However, we are by and large, since adenocarcinoma is the predominant one, we are going to concentrate only on that. And as you can see now, it's not EGFR all cross1, but the PDL1 expression level as well. And then we need to look upon the tumor mutation burden, whether it is less than 10 mutation MB or whether it is more than 10 mutation MB. And if it is more than 10 mutation MB, can we go with the immunotherapy or not? So this is all these are the driver actionable mutations. What you can see over here is like EGFR sensitizing, KRAS, ALK, and so on. And as I mentioned, the squamous, you can see EGFR amplification, DDR2, FGFR1, PIK3CA, P10, PDGFRA, FGFR2, and so gradually the WHO classification is going to have a paradigm shift from histology, morphology based classification towards the driver mutations present in the lung cancer. So prevalence of oncogenic, as you have seen over here, like KRAS, ALK, MET exon 14 skipping, BRAF, ERBB2, MET amplification, ROS1, and NRAS and MAP2K pathways. And these are some of the NRG1, BRAF fusions. All these are the fusions which has an important role. So this is one of the which was published in Nature Review, which is showing that the KRAS G12C has a higher percentage as compared to Asian population. Similarly, it goes with the MET splice. However, ALK fusion has shown a higher percentage compared to white. And ERBB2, again, the Asian population stands high in the expression. And of course, the EGFR exon 20 insertion, which has become a very hot topic as coming with the precise treatment of amivantamab. Red fusion, BRAF are almost similar in the white and as compared to Asian and black. And ROS fusion, again, it is very high and in the black population as compared to the white and Asian. This is a very interesting finding which has been published in the Nature Review. So, survival of patient with drivers in lung cancer. So as you can see, this is one of the data which was published, analyzed in 733 patients for 10 genes. And you can see over here that MEC1 was just 0.3% as compared to other EGFR mutations present. So EGFR, KRAS have been the highest, which you all know that this is the almost we can say these sensitizing mutations are the hallmark to treat the patient with the targeted therapy. And you can see that we have seen the wonders how the targeted therapy have increased in the survival rate, and without no mutations or with no drivers where they have to go with the chemo, the survival rate is very low. So LCMC demonstrated that best outcomes are seen in patients with the identified drivers placed on targeted therapy, considering the median value of 3.5-year median survival. So the potential application in uncommon mutations beyond EGFR and ALK, as you can see over here, are the FGFR, BRAF, MET splice, MET amplification, and many of them like T790 mutation and so on. So ROS1, RET, BRAF, V600E, MET splice, MET amplification, ERBB2 are considered to be the rare mutation. And again, you can see ERBB2 just not amplification, but mutations are also quite important, considered as a rare mutation. This is the data from MSK-KCC and impact lung adenocarcinoma. So majority of these common and uncommon driver mutations have shown that for every driver actionable mutations, now there are several targeted therapy available as a first line. EGFR, again, as I said, amivantamab and mobocertinib have become the hot topic, and we need to really detect, and only this can be detected on NGS and not any other platform like Sanger sequencing or real-time PCR platform. MET, again, capmatinib, tepotinib. HER2, you have the trastuzumab, deruxtecan. ROS1, again, we have crizotinib, entrectinib, BRAF, RET fusion. We have selpercatinib and NTRK fusion, again, you have the entrectinib and lerot. So the point is whether, and of course, the EGFR, it goes with the serially like gefitinib, erlotinib, afatinib, osimertinib, and decomitinib. However, osimertinib is also considered as the first-line weapon for the targeted therapy in the EGFR mutation. Again, with the KRAS G12C, though earlier it was just a prognostic or predictive marker, now we have got a precise treatment for G12C. However, in India, it is still not available, but you can see adagrasib is another, the latest therapy which is available. So biomarker testing in lung cancer, it is a moving target. As you can see, we have a march past from EGFR to many of the mutations now, driver action mutations which are present. So what does the NCCN guidelines says? It says that minimal, we need to have a 15 gene panel because we have the treatment as the first line therapy. We have PDL1, then again we can go with the carboplatin and so on. And pembrolizumab is also preferred for the immunotherapy as well. So 213 guidelines, we have again gone ahead with the 213 guidelines. Earlier, it was just EGFR mutation and ALK. There was insufficient evidence to support on NGS panel. But however, you can see that in 2018 updated guidelines says other than EGFR, we have to have BRAF, ERBB2, MET-RET, and use of cell-free DNA for testing when tissue is not available. And ASCO NCCN guideline also extended the recommendation to include the routine first-line BRAF mutation testing. So ROS1 gene rearrangement and another NGS panels preferred over single gene tests beyond first 3 EGFR, ALK and ROS. And therefore, this is the non-squamous histology. Like we need to have minimal at the first line itself, like PDL1 by IHC, EGFR, ALK, ROS1, BRAF. And for the squamous also, you can go for the PDL1 IHC. And recommended is RET, MET exon 14, HER2, KRAS, and TRAC. So biomarker testing for patient with advanced NSCLC is a real world issue and the tough choices which has been considered and which was published in the 2019 ASCO educational book. Mechanism of these are some of the resistant first line of EGFR TKIs, like when you can see a T790 mutation, T790 alone, or with EGFR amplification, or with other EGFR point mutation, like you can see EMT, HER2 amplification, BRAF, MET amplification, PIK3CA, and again we can bypass the tracks for around 20% of this. So rare mutation, again, I won't go into the detail because we are discussing only about the first line biomarker testing, role of first line biomarker in this. When I mentioned about we need to economize on the use of tissue. Each core of tissue be blocked separately. Initial diagnosis completed using 4 sections. Go for upfront reflex molecular testing, IHC or fish paste for specified marker, and appropriate number of tissue sections are cut first time. So no repeated trimming of block and vestige of tissue should be considered. And that, of course, we need to control the turnaround time for that. So the other alternative, if the FFP tissue is a problem, is again the liquid biopsy. So several studies support the use of plasma genotyping as a first-line testing to detect T790 mutation. Tissue biopsy would be required only when T790 mutation is not detected in plasma, as false negative rate of 30% is associated with the plasma genotyping. Treatment response to tissue or plasma detected, sensitizing mutation almost remains the same, but the recommended and established use of first-time osimertinib may largely prevent the development of T790M resistant and has a better CNS presentation. So these are like, I've already mentioned about this. So ALK, we need to look for the ALK rearrangement. Either you can do the method of identification can be IHC, FISH, RT-PCR, or NGS, which can be as a part of multigene assay. Next is the ROS1. Same again, sensitive to ROS1 inhibitor are the crizotinib and entrectinib. However, there are activation of downstream oncogenic pathways as well, like STAT3, PI3K, AKT, mTOR, and RAS-MAPK pathway. So either it can be detected by FISH, IHC, using D4DX, SP series 384 on Ventana, and of course NGS is recommended as a multi-gene assay. For the BRAF, again, we need to look for the dabrafenib plus trametinib patient with previously treated BRAF mutant metastatic NSCLC, and open label multi-center, it has been done on the phase 2 trial, and it has shown that dabrafenib plus trametinib in patient with previously untreated BRAF mutation patients, metastatic lung cancer, it is an open label of the phase 2 trial. So these are the several trials which have been, it has been published in the Lancet Oncology. So to highlight is, dabrafenib plus trametinib could represent a new targeted therapy with a robust anti-tumor activity and a manageable safety profile in patients with previously treated and untreated BRAF V600 patients in the mutated, in the metastatic NSCLC. So recommended should be what? Like MET exon 14 skipping, again, is an important marker. It can be either the disamplification or dysregulation of the MET pathway. Many times, MET amplification is seen as a resistance.
Anuradha ma'am, sorry to interrupt you. Please conclude your topic next minutes.
Yes, I'll go with this very fast. I will just further interact the efficacy of this energy fusion. So these are very important first-line biomarkers. Again, biomarkers for immunotherapy, no robust biomarkers, still is in progress. However, you can look for MSI, tumor mutation burden. There are different ways of looking at the same problem, gene expression signature, PD-L1 IHC, a therapeutic specific biomarker, and tumor microenvironment, tumor inflammation. These are the main biomarkers which have been looked upon as to look for the therapy as a marker, as a treatment. So metastatic NSCLC first line or the second line, later line treatment, you can look for the indications of immunotherapy present if you have a TMB present or PD-L1 present. The locally advanced stage 3 NSCLC, again consolidation treatment, you can go with immunotherapy. So the current standard recommendations for immunotherapy is first line, you can go with the PD-L1 positive, pembrolizumab monotherapy, TPS more than 50%. In combination with CT, again TPS less than 50%. If in the second line, in the later line treatment, again if the pembrolizumab TPS more than 1% or nivolumab, again any TPS can be considered. So again, I won't go much into the detail about this. So to conclude, lung cancer remains an archetypical typal example of tumor type enriched for rare oncogenes, challenged over conceptions of mechanism of oncogenes, and reshaped over our approach to molecular diagnostics. Extensive role of biomarker testing is very much essential, and NGS is the only solution. Either it can be done on liquid biopsy or on the FFP tissue. So multidisciplinary approach is essential for the quality information within the required time frame at a judicious cost. So incumbent upon the pathologist to make the testing reliable, optimizing pre-analytical, analytical, and post-analytical steps are very, very important on NGS. Thank you.
Thank you, ma'am. Thank you, ma'am, for such a wonderful talk. And as we move forward, I would like to invite Dr. Shyam Agarwal, sir, who is Chairman in HOD, Department of Oncology at Sir Gangaram Hospital, Delhi, for his talk on integration of antibody drug conjugates, ADCs, into the care of patients with non-small cell lung cancer, HER2 alterations. Over to you, sir.
So thank you very much for the invitation, Dr. Chaudhary. So
Thank you, sir.
Yeah. All right. Can we have the next slide? Next slide, please. Okay. So I think the topic given to me is to discuss on the antibody drug conjugates in non-small cell lung cancer. So it's a huge field now which is opening up in order to treat patients with a variety of cancers, including non-small cell lung cancer. So next slide will briefly tell you what the antibody drug conjugates are. As you can see, the antibody is used to guide the system for cytotoxic drugs. There's a linker, which is a bridge between the antibody and the cytotoxic drug. And then, of course, you have the cytotoxic payload, which is the warhead for destroying cancer cells. So that's the structure of the immunoglobulin with the cytotoxic payload. Next slide. So that tells you as to how these drugs work, which we are all aware. So the antibody will bind to the cell surface receptor present on the tumor cell. So there's an antigen and the antibody binds to that. And then there is internalization via endocytosis. And through the lysosome, there's degradation of ADCs in the lysosomes. And that leads to the release of the cytotoxic payload, which could be a microtubule inhibitor or another drug. And that, will kill the cell. Next slide. So that payload, which is attached to the antibody, is extremely, extremely powerful and toxic than the chemotherapy and the targeted drugs. And that is the other interesting aspect of ADCs, that there is a bystander effect, because the tumor cell, when lysed, the cytotoxic payload is released in the microenvironment and also directly kills the tumor cells. Next slide. So that's the basic information about antibody drug conjugates. Now coming to the non-small cell lung cancer, which are now available or being researched, and some of them are approved, which are directed towards HER2, HER3, TROP2, CMET, and B7H3. So I'm only going to be talking about the first four of them in a little detail. Next slide. So now coming to the HER2 alterations in lung cancer, as you are seeing here, there are three types of alterations. There can be a HER2 overexpression. At 3 plus, that is seen in less than 5%. Gene amplification by FISH or by NGS. I think the more important that again occurs in around 2 to 3% of NSCLC, and that can be identified by sequencing or by NGS. Next slide. So there are a lot of slides in this, session, so I'll rush through them. So you need to understand the sites of mutation in HER2 gene. Nearly the gray, is showing you the extracellular domain mutations, which are seen in about 25%. But I think in the left hand of the cartoon, you can see exon 20 and exon 19. So which is the red and the the blue one, which are the more common HER2 mutations, which are sort of targetable and targeted with this TDXD. Next slide. Can we have the next slide, please? Okay, so I think there are two antibodies which are available. One is the TDM1 and the other one is TDXD. And I think we are all aware of the differences between the two, because the cytotoxic payload is 8:1 and the linker is sort of different. And TDXD is much more potent than as compared to TDM1. Next slide. So the topoisomerase inhibitor is the payload in TDXD, and so that is more potent. Now coming to the use of TDXD in HER2 altered advanced non-small cell lung cancer in the Destiny Lung 01 study. So these were patients who were heavily pre-treated and had failed all standard treatments, so refractory patients. There were two groups. Cohort 1 was HER2 overexpressing, and cohort 2 was patients who had HER2 mutations. And these patients were treated with the TDXD, and overall response rate was the primary endpoint, followed by other secondary endpoints such as duration of response, PFS, and OS. Next slide. 91 patients with HER2 mutation in NSCLC were included in this study. Next slide. So, as I said, they were heavily pre-treated. And as you can see, these patients had a response rate of more than 50%. Show the previous slide again. The previous slide, please. Okay, you can see 54.9% patients of these patients had which is a very, robust kind of a response rate. And next slide shows you the PFS and overall survival. And 9 months and almost 18 months is the overall survival. So, these are patients. Next slide, please. Can you move the slides, please? Hello?
Hello. Yes, sir.
Can you? Next slide, please.
Okay.
So you can see nearly 8 months of PFS and almost 17.8 months. So this is really very encouraging for patients who have HER2 mutations or HER2 overexpression. And the dose is, in this study was 6.4 mg per kilo. Next slide. So these are some of the side effects. I think we are all using TDXD, and interstitial lung disease is the one which is, occurring almost at 4 months after use of TDXD. And most of these patients have grade 1 or 2 interstitial lung disease. Next slide. So then came the randomized study, which was, between the two doses of 5.4 milligram per kilogram versus 6.4 milligram per kilogram in patients, who had progressed on minimum one line of chemotherapy. and these are patients who had HER2 mutations. So next few slides, you will show the differences between the dose of 5.4 versus 6.4 milligram per kilogram. Next slide. So these are again some of the toxicity data. So I'll skip this. Next slide. So again, you see the response rate of which was almost equal, 50% versus 56%. So not much to choose between the two dosages of 5.4 versus 6.4 milligram per kilogram. Next slide. And again, if you see the progression-free survival, although with 6.4, it is a little high, 15 months versus 9.9 months, but the overall median survival is again touching 20 months with 5.4 milligram. Next slide. So I think, again, these are the Asian data, which are sort of confirming the data which is seen in the previous study. Next slide. So actually, if you look at the interstitial lung disease with 6.4 milligram, it is actually a little bad, 40% versus 13%. Next slide, please. So basically, the side effect profile was unfavorable for 6.4. And the other issue was the brain involvement in patients with lung cancer. So they pooled the data from Destiny Lung 01 and Destiny Lung 02. And can we have the next slide? So I think as we are aware from the data in breast cancer, you can see the response rates are better to the tune of 50% in 14 patients with brain mets versus 30% with 6.4 milligram per kilogram. Next slide. So I think I'll just skip these slides in the interest of time and basically reiterating that patients with brain metastasis have a reasonably good chance of responding to TDXD in NSCLC as well. Next. So, based on these data of brain response and the overall response rate and the PFS and overall survival, TDXD was approved for patients who have had earlier chemo or immuno at the dose of 5.4 milligram per kilogram. And patients should have an activating HER2 mutation. Next slide, please. So now further studies are ongoing of combining TDXD in the first line alone or in combination with immune checkpoint inhibitors, so for patients with HER2 expression. So different, studies are being done in first line and in subsequent lines. Next.
Thank you, sir.
So, no, hold on. So I think there are more slides there. If I have time, then I can go on.
So 1 minute is left.
Okay, so as I said, there are a lot of slides. So TROP2 is another, next slide. So this is the transmembrane glycoprotein, which is involved in, molecular oncogenesis, which leads to, cell proliferation. And so if you can block the TROP2, then there is a possibility of inhibiting the tumor cell growth. Next slide. So these are some basic slides which show that the tropion pan-tumor study, irrespective of the tumor type, the patients can benefit. Next slide. So the drug which is used is called datopotamab or dato-DXd, and irrespective of the degree of expression of, the TROP2, patients can benefit. Next slide. So this is, there are two drugs there. One is the datopotamab and the other drug is sacituzumab govitecan. And you can see the payload is the topoisomerase inhibitor in the the dotapotamab. So again, basically they are the TROP2 inhibitors. Next slide, and SN38 is in the sacituzumab. So this is another drug which has shown efficacy not only in patients who are EGFR wild type, but also in patients who are harboring EGFR mutation. Next slide. So basically, the effort is, next slide, to demonstrate the efficacy of datopotamab or TDXD in the second line in comparison to docetaxel. So this was actually the most touted kind of a study, and there were encouraging results. But then I think only yesterday in the WCLC, the overall survival benefit has not been shown. And therefore, this is a study which we were very keenly looking forward to, is sort of not coming up. Next slide. So I think these slides will have very less meaning, although initially there was a lot of benefit on the PFS, which was statistically significant, but the overall survival in the Tropion Lung 1 study has not stood the test of time in the non-squamous. So can we leave like 5-10 slides? Next slide, go on, please, because I think just because of the data which I've just narrated, so this has not stood the test of time. Similarly, next slide, I think we skip this. Next. So now people are trying this Dato-DXd with other immune checkpoint inhibitors and chemotherapy, and the results are awaited. Next. So I'll just go to the last part of the talk. Next, please. Next. So these are other, we'll skip this. Yeah, right. I'll just want to talk about this HER3. So previous slide. Yeah. So this is the patritumab deruxtecan, which is targeting HER3, ADC. And this is again, there is a topoisomerase inhibitor, which is the payload here. Next slide. So now you can see here that in the Harthena Lung 1 study, these patients who have had EGFR and the chemotherapy drug, so they were given patritumab, and I mean, these are phase 1-2 studies. Next slide. And you can see, almost 30% patients responding to this particular ADC, which is targeting HER3, which is patritumab in Harthena Lung 01 study in patients who are not responding to EGFR TKI. So these patients were, EGFR positive. Next slide. So irrespective of the type of resistance mechanism, the patients are benefiting to the tune of 30%. That is the response rate with the patritumab. Next slide. So if you look at the prior EGFR TKI and patients who have had third generation TKI, the response rates are similar to the tune of 30%. Next slide. So I think these are the side effects. I'll not go into that. Next slide. Yeah, so next, again, I think you can see that these patients have a response rate to 30% and the PFS of 8 to 10 months. And there's an association between the baseline, HER3, which can be seen here. Next slide. So I think these are ongoing studies. There is no approval of this drug, but you can see that these are various other ongoing studies in which people are trying to combine this in the second line and looking at the CNS penetration and the brain metastasis. So suffice it to say, in the end, so I think we have HER2 targeting drugs. For example, as I showed you about the TDXD data, which is very promising and approved for HER2 mutation and even for HER2 expressing non-small cell lung cancer. The other is I told you about the Dato-DXD, which is again now being combined with other agents to see the efficacy in the second line in non-small cell lung cancer. We do have sacituzumab govitecan, but again, the data is preliminary there. And now you have the HER3 directed ADC, which is called the patritumab. And again, the data seems promising in patients who are failing on EGFR TKI. So I think these are, areas which we need to look upon in the near future as to how the, results are evolving, so as to incorporate these drugs in our day-to-day practice. So thank you very much for the invite.
Thank you, sir. Thank you for your wonderful talk. And next, as we move forward, the next session is sponsored by Roche. For this, I would like to invite Dr. R.K. Chaudhary, sir, for the talk on optimizing treatment strategies and management of first-line MNSCLC. Over to you, sir.
Thank you for kind introduction. And before I start my talk, I would like to thank you, Dr. Shyam Agarwal, sir, for such a nice and wonderful update about the ADC. We know that in the next couple of years, we are going to use more and more ADCs in almost many patients, and many indications are there coming. So thanks, Roche, for providing me slides. And this is the schema of today's presentation. Thank you. Good evening to everyone. So I'll be going to discuss about the first line treatment options in the metastatic non-small cell lung cancer. So schema will be like disease background of the non-small cell lung cancer, then evolving landscape of lung cancer treatments. Then I'll briefly touch upon the 3 studies involving the atezolizumab, which is IMpower 110, IMpower 150, and IMpower 130. Then I'll summarize my talk. So I'm audible properly?
Yes, sir.
Right. So am I able to move my slides, or somebody else need to move?
No, sir.
So can you move to next slide, please?
Sir,
I need to do that. Can you move on to next slide, please? Next slide, please. So this is about the brief background of the non-small cell lung cancer. This is a slow-growing tumor with varying initial overall response rate according to driver mutation and targeted therapies. Non-small cell lung cancer account for about 80 to 85% of the all lung cancers. 15% of the patient with non-small cell lung cancer happens in the never smokers. Median age of presentation for non-small cell lung cancer are 70 years, and typically presenting features are cough, chest pain, and dyspnea. Metastasis occurs later in the disease progression. 55% of patients have distant mets at the diagnosis. Targeted agents have improved survival rates in non-small cell lung cancer, specifically those patients who have the driver mutation. Next slide, please. So this is the evolving landscape of lung cancer treatment. In 80s, we used to classify lung cancer as the non-small cell lung cancer versus the small cell lung cancer. Then in 2000, there comes the histological subtype where they started dividing the non-small cell lung cancer into the squamous type, adenocarcinomas, large cell, and neuroendocrine subtypes and small cell carcinomas. And introduction of anti-angiogenic drugs came, and their use with the combination chemotherapy were started. Then came the molecular classification with the availability of the molecular markers and their targeted treatments, like specifically EGFR, ALK, ROS1. Then came the BRAF and KRAS, then NTRTK and HER2/neu, and so on. Then subsequently came the PD-L1 and cancer immunotherapies. Next slide, please. So there is an unmet need in the treatment of patient with the non-small cell lung cancer with no actionable biomarker. For actionable biomarker, we know there are clear-cut guidelines, and to use the molecules which are specifically works on that actionable mutation. So now, what are the options for the non-small cell lung cancer with no actionable biomarkers? Overall survival is stratified by the therapy types in the patient with non-small cell lung cancer. Various therapies which are available for this class of non-small cell lung cancer are targeted therapy, non-targeted cytotoxic therapy, and observation. And we see clearly observation is not an option with chemotherapy. There is a better results as compared to observation, and if we combine the chemotherapy with the targeted treatments, then it further improves outcome in non-small cell lung cancer. Molecular profiling of the 70,000 odd patients with non-small cell lung cancer by the French Cooperative Thoracic Intergroup showed then KRAS being the one of the most common mutation found in about 29%, then EGFR 11%, HER2/neu 1%, BRAF 2%, ALK mutation in 5% of patient, PIK3 mutation in 2% of patient, and complete wild type in 15% of patient. However, a significant portion of the patient comprising 35% of the non-small cell lung cancer have no known actionable biomarker till date. Next slide, please. So global phase 3 studies of the atezolizumab in the first line treatment of non-small cell lung cancer. There are 3 trials which I am going to present today. Is Iron Power 110, which is study in the non-squamous as well as the squamous cell lung cancers. Number of patients included were 572. There was 2 arms, atezolizumab versus study arm was the atezolizumab, and the control arm was the carboplatin cisplatin plus pemetrexed if it is non-squamous cell lung cancer, or carbo-cis plus gemcitabine in squamous cell carcinoma. The question asked in this trial was, is atezolizumab monotherapy a better result than chemotherapy in PD-L1 selected chemotherapy naive patients? In IM Power 130, number of patients were around 723, and only non-squamous non-small cell lung cancer were selected. The question here was, is the steroid-sparing chemotherapy regime a better combination partner for atezolizumab? In IM Power 150, non-squamous, again, only non-squamous non-small cell lung cancer were selected, and patients were more than 1,000, around 1,202 patients. And the question here was, does the addition of atezolizumab to the standard of bevacizumab plus paclitaxel and carboplatin add any clinical benefit? And is there any improved clinical benefit if the bevacizumab is replaced by atezolizumab? Next slide, please. Next, please. This is at IM Power 110, where the squamous as well as the non-squamous non-small cell lung cancer was were included. A randomized phase 3 multi-center study. Stage 4 non-squamous non-small cell lung cancer, chemotherapy naive, PD-L1 selected, EGFR ALK negative patients. Stratification factors were gender, ECOG PS, histology, PD-L1, IHC expression. Total number of patients selected were 572. Atezolizumab was used in a standard flat dose of 1200 milligram every 3 weekly. Initial 4 to 6 cycle response assessment, and it was continued till the progression, disease, or loss of clinical benefit, or it was not tolerable. In the control arm, it was non-squamous. For the non-squamous, chemotherapy was pemetrexed plus platinums, and for the squamous, gemcitabine plus platinum. Initial 4 to 6 cycle, followed by maintenance pemetrexed in non-squamous non-small cell lung cancer, and there was no maintenance in squamous cell non-small cell lung cancer. And maintenance therapy was continued till the progressive disease. Primary endpoint was overall survival in wild type population, excluding patient with EGFR and ALK positive non-small cell. Key secondary endpoint were PFS, overall response rate, and duration of response. PD-L1 positive was defined as TC123 or IC123, PDL expression more than 1% of TC or IC. Next slide, please. So prevalence of the PD-L1 expression was like it was comparable in all the subgroups, both in the study as well as the comparative arm. So it was similar in the all, whether it was IC3 or IC2 or IC3 1. Next slide, please. Coming to the baseline characteristic like age, gender, white, Asian, never tobacco smoker, and non-squamous histology and ECOG PS, it was similar or well balanced in between the arms and the PDL1 subgroups. Next slide, please. So primary endpoint of the OS in the TC3 or IC3 expression subgroup was met, and median OS was improved by 7.1 month with atezolizumab over the chemotherapy. Here the median PFS was 13.1 months versus median OS of 20.2 months in the IU therapy, IU arms. At the landmark of 6-month OS was 76% in the arm A versus 70% where the chemotherapy was used, and at 12 months OS of 64.9 months was observed with the immunotherapy versus 50.6 months with the chemotherapy, with a hazard ratio of 0.59 hazard ratio of 0.59. Next slide, please. So coming to subgroup analysis of OS, and OS benefit was, here we can see that OS benefit was observed in all the clinical relevant subgroups, whether whichever age bracket were chosen, whether less than 65 or 65 to 74, 74 to 84, it was seen in overall all the subgroup, but it was less when 75 or more. Seen in the both the genders, male or female, white and Asians, never used tobacco. There was no benefit. The current smoker and previous smoker benefit was seen. Irrespective of histology, benefit was seen, and irrespective of the ECOG PS, benefit was seen with the immunotherapy versus chemotherapy. Next slide, please. So at the updated analysis, exploratory OS analysis in the high PDL1 expression wild type population, continued OS improvement was observed in the atezolizumab group versus chemotherapy arm with median OS of 20.2 months versus 40.7 months in the chemotherapy arm. Next slide, please. So coming to the subsequent cancer therapy after the progression. So immunotherapy was received by the 35% of the patient in the control arm who progressed on the chemotherapy arm. And the proportion of patients who received the different classes of the subsequent cancer therapy was similar across the PDL1 subgroups. Next slide, please. So OS overall survival hazard ratio more strongly favored the atezolizumab versus chemotherapy after adjusting for the subsequent immunotherapy use. So at the exploratory updated analysis, 35% of the patient in the control arm received the subsequent cancer immunotherapy, and the OS hazard ratio more strongly favored atezolizumab after adjusting for the effect of subsequent cancer immunotherapy using the RPSFT method. And we can see that OS was better in the atezo arm. Next slide, please. And an additional pre-specified PDL1 biomarker analysis was performed using the DECO platform with the clone 22C3 PDL ISCSA, and on the Ventana platform using the SP263 clone. And by this time, we are aware whether whatever method we use, they are more or less there is concordance with the different methods. And here also in this trial, whether using SP142 or SP263 or 22C3, benefit was seen across whichever method was used for the PDL1. So median overall survival was similar in whichever method was used. In SP142, it was 20.2, and if we used like 22C3, then again the median OS was similar, 20.2 months. With the SP263, median OS was the same, 19.5 months. Next slide, please. Next slide, please. Coming to the PFS in IMpower 113, that there was clinically meaningful improvement in the PFS in the atezo arm. At 6-month PFS was 59.8 months versus 38.3 months in the chemotherapy arm, and at 12 months, PFS was 36.9 months were in the atezo arm versus 21.6 months in the chemotherapy arm. So clear-cut benefit in the PFS was seen. Next slide, please. Again, at the in the TC3 or IC3 group, at the updated analysis, there was continued to be clinically meaningful improvement in the PFS was seen. So median PFS was 5 months in the chemotherapy arm versus 8.2 months in the chemotherapy immunotherapy arm. Next slide, please. So TC3 or IC3 population, wild type population, overall response rate was also improved with the atezo arm versus chemotherapy. 40.2% patient responded in the immunotherapy arm versus 22.6% in the chemotherapy arm. Next slide. This is the updated safety profile, which was largely both the immunotherapy was found to be the safe with the class effect of the immunotherapy was seen. And if we talk about the overall adverse effects, which were more common in the chemotherapy arm, all grade 3 and 4 adverse effects was reported to be 50% of the patient in the chemotherapy arm versus 30% in the immunotherapy arm. Immune mediated adverse effects are, of course, more in the immunotherapy arm. Immunotherapy mediated AI adverse effects requiring the corticosteroid use were around 10% of the patient.
Dr. R.K. Chaudhary, sorry to interrupt you. Please conclude your talk in next 2 minutes.
Right. Next slide, please. So these were the. Can you skip the slides? We'll come to the next. Please skip the slide and come to the next summary. Okay. Go back to one slide. Go back, please. To summarize, the IM power 110 atezolizumab represent a promising first-line treatment option in patients with PD-L1 high non-small cell lung cancer. IM power 110 is a positive study that demonstrated a statistically significant with clinically meaningful improvement in OS in the TC3 IC3 wild type population versus platinum-based chemotherapy with a hazard ratio of 0.59. In the TC3 or IC3 wild type population, atezo showed meaningful improvement in PFS, overall response rate, and duration of response versus chemotherapy. The safety profile of the atezo was consistent with the prior observation and no new or unexpected safety signals were identified. Atezo had a favorable safety profile compared with the chemotherapy, and the safety data were consistent with those with pooled atezo monotherapy population. Coming to next slide, please. So, next, please. So IM power 150 is the phase 3 study of the first line atezo plus chemotherapy and bevacizumab in non-squamous non-small cell carcinoma. Here is the schema of the study where the three there was the three arms. One was the atezo plus chemotherapy, where second was the atezo plus chemo plus bevacizumab, and third was the chemo plus bevacizumab only. The stratification factor was the gender, sex, PD-L1 and liver metastasis. This was the rationale for combining the 4-drug chemo plus target. So bevacizumab inhibits the VEGF-mediated suppression of dendritic cell maturation, enabling efficient priming and activation of T cell responses. Bevacizumab also normalizes the tumor vasculature, resulting in an increased infiltration of T cell into the tumor. Bevacizumab decreases the activity of MDSC and Treg cells and enables reprogramming of the tumor microenvironment. Chemotherapy-induced immunogenic cell death can trigger the release of tumor antigens, and atezo's ability to restore anti-cancer immunity through T-cell-mediated cancer cell killing is further enhanced through the bevacizumab VEGF-mediated immunotherapy effects. So next slide, please. So I'll coming to the conclusion of IM power 150. Please skip the slides and come directly to the conclusion of the trial. So these are the various subgroup where the benefit was seen with the 4-drug combination compared with the only 3-drug combination. And coming to the conclusion of the IM 50, one slide back. 114 back. One slide, please. So to conclude, IM power 150 met both its co-primary endpoint as and the first and the only phase 3 immunotherapy plus anti-VASP combination study to demonstrate a statistical significant and clinically meaningful improvement in the PFS and OS in all comers, first line non-squamous metastatic non-small cell cancer. Clinical meaningful PFS and OS benefit were observed in all the patients, including key clinical subgroups such as patient with EGFR positive and ALK positive and liver metastasis. The clinical benefit from addition of atezo to bevacizumab and chemotherapy was observed in patient with and without bulky disease, further supporting use of this regimen as the first line option for patient with high disease burden. Atezo in combination with chemotherapy and bevacizumab appears to be well tolerated and its steady profile, safety profile is consistent with known safety risk with atezo. Next, please. So I'll present 2 slides only. So this is IM power 130 where non-squamous non-small cell lung cancer were included in phase 3 study of carboplatin and nab-paclitaxel with or without atezolizumab in first line advanced non-squamous non-small cell lung cancer. Next slide, please. Next, please. This was the rationale for combining chemo plus immuno. These were the stratification factor and these were the study arms. Nab-paclitaxel plus chemotherapy with the study steroid sparing agent pre-medication was used, and arm B was carbo plus nab-paclitaxel. Next slide, please. Come to the skip to the conclusion, please. We have many slides even after that. Next. Go back to 2 slides back. So key conclusion of the IM power 130 or IM power 130 was a positive phase 3 study of for atezo in first line non-small cell lung cancer, providing an alternative chemotherapy plus immunotherapy plus chemotherapy regimen for patients with chemotherapy naive non-small cell lung cancer. IM power 130 demonstrated statistically significant and clinical relevant OS benefit when atezo was added to carboplatin plus nab-paclitaxel despite the high crossover rate. IM power 130 demonstrated a PFS benefit and a higher overall response when atezo was added to chemotherapy. An OS and PFS benefit was observed across key clinical subgroups except in patients with EGFR and ALK positive non-small cell lung cancer or patient with liver mets, supporting use of IM power 150 regimen in those patients. Atezo plus chemotherapy had a safety profile consistent with AI associated with single agent therapy. No new safety signals were identified. In the interest of time, I'll conclude my talk here. Thank you so much, and thank you, Rosh, once again for providing me the slides.
Yes, sir. Thank you for the wonderful talk. And we move forward for the next session, which is sponsored by our academic partner, INTAS. And for that, I would like to invite Dr. Mohit Agarwal, who is Senior Director and Unit Head Medical Oncology at Fortis Shalimar Bagh, for his talk on advances in novel formulations of taxanes. Over to you, sir.
Okay, thank you, RK, for this elaborate talk and also giving me this opportunity. So I would like to share my screen. I hope this is visible.
Yes, the slides are visible. You just need to make it full screen. Yes, sir.
Okay, so I think it's full screen now.
Yes, sir. It is perfect.
Okay, so thank you, Intas, and thanks, RK, for this opportunity. So I'll be talking about newer formulation of vaccines and the requirement for this. So without delay, I'll come on to the context. Okay, so this is how I plan to go about, which is the overview, the snapshot of the ASCO-ESMO publication, the ESMO in head and neck carcinoma, and some data about this formulation in gastric adenocarcinoma, and followed by summary. So if you see taxane, it forms the backbone of our cancer management in terms of chemotherapy. Drug from taxane group discovered way back in 1980, where the mechanism of action is obviously the microtubule inhibitor. The chemotherapy, as a chemotherapeutic agent, started its role in 1990, and its approval was in 1996 in metastatic breast cancer. Now, what are the challenges with this compound, which has been the, something like the backbone of our treatment, is something like some toxic issues with the solvent, which is the presence of the chromophore, which is the polysorbate ATP. Now, this component, which is either solvent, has known to cause hypersensitivity reactions. It leads to peripheral neuropathy, fluid retention, hepatotoxicity, and neutropenia. So, also the problem is that you need to give these agents with some specialized sets, which are known as codon IV sets, because if you use the normal plastic in the PVC, it causes the leaching of the same, and which can, cause again allergic reactions to the patient. And obviously, since this compound is not safe in terms of the solvent, the use of gloves is recommended, and no contact with skin immediate. If there is a contact with the skin, and immediate thorough wash is required as in every case. So if you see we usually give something like a steroid pre-medication, but you see here that without steroid pre-medication, the chances of hypersensitivity are about 30%. But when you give steroid pre-medication, it reaches to 30%. So steroids pre-medication helps in that case, and that is why they are supposed to be given. But still, the incidence is 13%. So in spite of all you do the best and you give your steroids, you have a 13% chance of some sort of a reaction to these drugs. And obviously, you need to know about the adverse effects of prophylactic corticosteroids used during docetaxel therapy. So it is recommended that we give 8 milligram of dexamethasone orally every 12 hours. A day prior to chemotherapy, 10 milligram dexamethasone IV administration before docetaxel, and 8 milligram again 12 hourly for 4 doses after docetaxel administration. So that is a lot of, steroids which is supposed to be given with these agents to prevent the reaction. Now, if you see the timeline of these taxane discovery, as I've already mentioned, that we have this discovery of docetaxel way back in 1980, then it started the use of chemotherapy metastatic breast cancer in 1996, and subsequently got approval in lung and prostate and breast cancer. But it was 2013 when we got some newer formulations of taxanes, which was NDLS in docetaxel, and the first nanosomal paclitaxel was in 2016. Now, what is the advantage of these newer formulation is that it is solvent free. It does not have that solvent chromophore which causes problem. So first of all, the hypersensitivity reactions are not there or minimal. There are no steroid medications which are required, and hence obviously there are no problems like a fluid retention, and it is a better choice for cardio-diabetic patients. So we have something like a nano aqualift technology, and what is it? I'll be going to talk about it. So NDLS is basically a lipid-based formulation where you see the problem with this molecule is that it is hydrophobic. So it is very difficult for it to transfer into the blood. Now, it is a special sort of a molecule which is made, which on exterior has a hydrophilic area, which can easily be, move inside the blood. And the exact core where the drug is actually hydrophobic, where the docetaxel molecules are attached. Now, the advantages of this design is that it is free from solvent, because the outer area is basically hydrophilic. And the naturally occurring, generally regarded as safe lipid excipient, which is used as soy phosphatidylcholine choline and sodium cholesterol sulfate, which are again considered to be safe when we are using in these molecules. Second important point is we know something about the nanotechnology these days, and we are really, working out with the fact that the nanotechnology is helpful in terms of the size of the molecule which we are getting, so that molecule is able to penetrate deep into the cancer tissue and can basically get us a better result. So the molecular size of this molecule is very optimum with about 100 nanometers, and it thus enables high penetration into tumor because we know that the cancer tissue has leaky vasculature, so the tumor penetration is high. And these do not enter into healthy tissue as they are larger than 10 nanometer particle size. So these are some publications which have been done for this molecule, and I'll be talking about a few of them. So this was ESMO 2023, where the positive safety results were announced from NDLS-based neoadjuvant therapy in head and neck squamous cell carcinoma. Sorry. So this was a large study by Tata Memorial Hospital Group, where the suspension or a docetaxel-based neoadjuvant therapy was compared in a head and neck squamous cell carcinoma. So we had these four groups, total about 500 patients, where we have NDLS in all the cycles in the first group, docetaxel in all the cycles in group 2, first cycle of NDLS and rest docetaxel in 64, and first cycle of docetaxel and rest NDLS in the another 50 patients. The patients either received a TTF or a TT regimen as a part of the randomized study. And what we are concentrating is group 1 and 2, where the major, comparison comes about. So if you see the efficacy endpoints between group 1 and 2, you see that the efficacy in terms of response rate and overall survival are nearly equal in both of them. There is no statistical difference. However, there is a numerical difference in favor of the other arm. However, it is not statistically important, but where it makes a difference is here, where it is the terms of side effects. You see here the group 1 in terms of leukocytes, in terms of weight loss, in terms of vomiting, in terms of diarrhea. You see, and especially in terms of neutropenia. So the two things which are really important with docetaxel is mucositis and neutropenia, and you say there is a significant difference between the two in favor of this newer formulation. So safety, significantly lower incidence of neutropenia and mucositis in NDLS subgroup. The difference is 41.1 versus 56.4, and mucositis 43.8 versus 65.7. Another paper was presented in the ASCO GI 2024 symposium in US. And this was again the safety and efficacy of this molecule, the newer formulation in patients with advanced gastric adenocarcinoma. So here what they used was the DCF or a modified DCS in patients with metastatic gastric adenocarcinoma. The majority of patients experienced grade 3-4 toxicities with DCF regimen using conventional regimen, and in this multi-centric open-label trial, they evaluated the safety of this newer formulation. So they tried to give this compound and replace the conventional docetaxel NDLS, either in a modified DCF where you give leucovorin 5-FU or with cisplatin 5-FU. So if you see here, the overall response rate was 57.5 and 60%, and the DCR rate was also very good, where it was 81.7 and 80%, meaning by that this compound is pretty safe. The median follow-up duration was 8.6 months with a median PFS of 8.4 months, and this was nearly similar to the other arm as well. And you can see the Kaplan-Meier curve for the progression-free survival, which was overlapping. In terms of the results and safety, you can really see here that the majority of adverse events were grade 1 and 2, and grade 3-4 adverse events were only about 40% of the patients, and most common grade 3-4 adverse events was neutropenia observed in the modified DCF group. So it basically came out with the fact that as compared to conventional classical data, what we have, the NDLS-based regimen demonstrated efficacy and improved safety profile in the treatment of metastatic gastric adenocarcinoma. So in summary, these conventional taxane are associated with significant adverse effects like the reactions, and pre-medications like steroids further increase the possibility of adverse events, and this is a big problem in patients who have a cardiac or a diabetic prior status. This molecule NDLS can be advantageous by avoiding the steroid pre-medication and minimizing the safety use. And NDLS-based induction chemotherapy has been now to be found effective, well tolerated, and has shown good response rate in the data, whatever has been presented. And NDLS-based regimens demonstrate efficacy and improved safety profile in the treatment of metastatic gastric adenocarcinoma. So this is all I have from my side, and thank you, and I hand it back to Robin.
Okay, sir.
Thank you, sir, for the wonderful talk. And as we move forward, the next session is sponsored by CIPLA, For this, I would like to invite Dr. Sajjan Raj Purohit, who is Senior Director, Medical Oncology at BLK Max Super Specialty Hospital at Delhi and Shalimar Bagh, for his talk on sequencing strategies for HER2 plus MBC. Over to you, sir.
Can you put the slides?
Yes,
Sure.
sir.
Thank you, Dr. R.K. Chaudhary, and the organizers for having me here. And thank you, Sipla. The slides are provided by the company. So the topic is sequencing anti-HER2 therapies in HER2 positive MBC. Next slide. So we now know that in HER2 positive metastatic breast cancer, over the time, our curves have grown. They moved more and more towards the right and upper quadrant. And we have seen a significant difference if you start from around 5 decades back. There's almost an absolute benefit of around 2 years in the survival. So there's a long success story in HER2 positive metastatic breast cancer. Next slide. We know that HER2, we have a lot of targets which we can really block. So we have, we know HER2 heterodimerases with either HER1 to HER4, and we have antibodies which are trastuzumab, pertuzumab, which have different domains but work very synergistically. And we have ADCs which act through the same domain as trastuzumab, but then they deliver the drug directly into the they deliver the drugs once they attach to the HER2 receptor. They deliver directly the drug to the into the intracellular domain and lead to antibody drug conjugate related killing. And now we have a lot of molecules. We have trastuzumab, pertuzumab, margetuximab, which are acting on one area. We have ADCs where we have your Kadcyla. This is TDM1. We also have NHER2 there, and there are many other ADCs which are under development. We also have small molecule tyrosine kinase inhibitors, which we include lapatinib, neratinib, apatinib, dacometinib, which are multi-kinase inhibitors apart from tucatinib, which is again I think a significant addition to the armamentarium. Next slide. So typically a first-line patient journey would have that around 20% of the patients actually we will lose after first line, they will not be fit. Only around 78% patient will be eligible for second line therapy, and around 65% patient will be eligible for third line therapy. So our aim actually should be actually to have the best first line therapy, so more and more people are able to be well on first line therapy, and if required, then they should also be able to transition to second line therapy and third line therapy. So the dropout, the more we are able to prevent the dropout rates at first and second line progression, we also should be able to improve the PFS1 and PFS2 so that the OS is impacted with these drugs. Next slide. Next slide. So with Cleopatra, we know that, So Cleopatra, we know that the study of trastuzumab, pertuzumab, and docetaxel, where we found that if we combine the 3-drug versus on the 2-drug combination, which was standard of care, there was a significant improvement in the median OS. It raised from 40.8 months to 57.1 months, and even a longer follow-up of median PFS was also significantly higher. And even the difference was maintained at 8 years of follow-up. So this was a landmark trial that established the 3-drug regimen as compared to the first line only taxane and trastuzumab combination. And most of us have adopted this into our clinical practice after Cleopatra. Next slide. Now coming to Destiny 9. Destiny 9 actually is the first line trial for HER2 positive metastatic breast cancer. And in fact, this is one of the, again, a landmark trial where this challenges the current standard of care, which is THP, where we have 3 arms randomized 1:1 to TDXD plus pertuzumab and THP. Next slide. So we really look forward to the results of Destiny 9. Now coming to the second line, Amelia and Theresa study have established that if you have prior exposure to trastuzumab plus taxane, then TDM1 could be a better choice compared to the previous standard of lapatinib plus capecitabine. Again, if you just saw that median OS actually improved from 25 months to 29.9 months. And Theresa also was a similar study where TDM was compared to TPC and the physician's choice. And again, there was a significant improvement. So in today's practice, before your N-HER2 becomes more readily available, I think most of the clinicians use THP and followed by TDM1. That's a usual practice. And then subsequently, we could use either lapatinib, capecitabine, even tucatinib could also come in and pitch in there. So there are like 4 or 5 lines of therapies, especially with now currently available drugs in metastatic hormone positive, HER2 positive breast cancer. Just give me 1 second. Sorry for the interruption. Next slide, please. Now we know about trastuzumab deruxtecan, and this has been a real valuable addition. We now know that this again is an antibody drug conjugate. It has got 3 components. One is humanized anti-HER2 IgG1 monoclonal antibody, which has got the same amino acid sequence as trastuzumab, covalently linked to a topoisomerase 1 inhibitor payload and exatecan derivative via a tetrapeptide bias cleavage linker. So there's a linker, there's a chemotherapy payload, and there's a monoclonal antibody. Next slide. So we now know that there's a big fight of TDXD versus TDM1, and where TDXD actually has had a huge benefit over TDM1. So coming next slide, please. So this was again established as the winner in Destiny Breast 03, which was again a randomized 1:1 diet head-to-head comparison of TDXD versus TDM1. The primary endpoint was PFS, the secondary endpoint was OS. Next slide. And you can just see the results here. The results were markedly superior in the TDXD arm compared to TDM1. And if we talk about the median PFS was 28.8 months versus 6.8 months. And if we compare the OS difference was also significant, where though it was not reached in both the arms, but the P value was highly statistically significant between TDXD1 versus TDM1. And we could actually see that there was an early separation of the curves, and this was maintained till the time of follow-up. So both the results were the longest PFS, which was reported with the TDXD, and also there was an improvement in the OS, though at the time of reporting, both the arms showed not reached for both the patients. Next slide. And in the real world also, it shows that second-line TDM1 is actually not the appropriate line for such patients. And that's why most of us are actually in patients who are affordable or reimbursable. We like to have TDXD compared to TDM1. Next slide, please. And in there are reduced outcomes with TDM1, especially with prior pertuzumab exposure because of reduced HER2 expression. That's the reason why TDM1 effectiveness is actually rendered ineffective in patients who have already been treated with first-line pertuzumab. Next slide. And if you just see, if there was if you just compare to TDM1 with TDXD, a prior use of TDX or pertuzumab had no effect on the benefit of TDXD compared to TDM1. So TDXD scored over TDM1 irrespective of the prior pertuzumab use. Next slide. Coming to HER-CLIMB was a study where patients had been treated with either pertuzumab, trastuzumab, or TDM1, were randomized 2:1 to tucatinib plus trastuzumab plus capecitabine, or to trastuzumab plus capecitabine. So this was a study with the tucatinib, where tucatinib was given to patients who had at least been exposed to one or both the important drugs that were available at that point of time. So trastuzumab, pertuzumab, and TDM1, all three drugs being exposed. And it showed that even in third line, there was an OS benefit of 21.6 months versus 12.5 months, and median PFS difference of almost doubling of 9.9 months versus 4.2 months. Next slide. NALA studies with niratinib plus capecitabine versus lapatinib with capecitabine. Obviously, there was no difference and there was higher toxicity. And in fact, that has led to niratinib failing out of favor. Next slide. So the previous standards have been actually THP in the first line, TDM1 in the second line, and third line, we had multiple options. Next slide. If we just see 2024, if finances are not an issue, we start with the Cleopatra, which is THP in first line, and Destiny Breast 3 as a second line, or we could go to even HER-CLIMB, which could be another option. And third line, we have options of Amelia, Thersia, or we could use, if we are not used previously, TDXD or tucatinib, which is HER-CLIMB. Next slide. Later lines also we have choice. We could have used, if the agents have not been used previously, we also have option, though in India it's not available, of Sophia, which is margetuximab plus chemo. I'm not personally very favorable for neratinib, but then if wherever available can be used. And then we could go to chemo or chemo plus trastuzumab in further lines of treatment. Next slide. And this is what it makes. In the first line, we have THP, which is platinum, taxane could be used dosi or pacli, though most of us, we tend to use paclitaxel in view of lesser toxicity. Second line has been TDXD now, wherever possible. Third line is, again, we have preferred categories for tucatinib, trastuzumab, capecitabine, but though we could use TDM1, and obviously later lines, we could use other combinations. Next slide. HER2 positive with brain mets. Next slide. So the pooled data from Destiny 1, 2, 3, it found that objective response rates were much higher in the TDXT arm compared to the TDM1. Next slide. So there was superior rates of control of disease in patients even with brain mets. And you could just see the overall survival as the PFS was much higher, both in the Destiny data as well as in the tucatinib HER-CLIMB study. So both these agents are more effective than TDM1 in patients with intracranial brain mets. Next slide. So this shows the various drugs and their activities, and the highest activities are with the drugs which are TDXD and tucatinib, to a lesser extent with the THP regimen. Next slide. Now, even with this HER2 positive, we're now having more and more receptors, and we are planning for tri-specific antibodies targeting HER2 and T cells. So these are the new ADCs and antibodies in trials. Next slide. So up to 55% of patients who have low HER2 expressions, they can also be offered TDXD. Next slide. And if TDXD is compared to the patient's, the physician's choice in HER2 low, which is IC 1+ or 2+ on FISH negative, such patients, if they were compared head to head, when they have been treated at least with 2 lines of prior chemotherapy, then just next slide. It has shown that there was a more than doubling of the PFS, as well as the also the probability of being on a failure-free survival also was much higher. So this shows that even in hormone positive patients or all patients or triple negative patients who have got low HER2 low positivity, this could be one of the options. This is data from Destiny 04. Next slide. The OS also was significantly improved from 17.5 months to 23.9 months in both the hormone positive patients as well as in the all the patients. Next slide. So the treatment landscape of HER2 positive disease is expanding. The sequence of therapies is changing. Newer therapies have significant intracranial activity and new targets are being explored. So this is a fascinating time for patients with HER2 positive as well as HER2 low positive patients, where we have much more options and we have chances of improving their PFS and OS, and that is really exciting. With this, I would like to thank all of you for patient hearing and back to organizers.
Thank you, sir, for wonderful talk. Next session is sponsored by Roche. For the next talk, I would like to invite Dr. Pooja Babbar. She is a consultant medical oncology at CK Birla Hospital, Delhi. Ma'am will give talk on a flexible future transforming the paradigm of HER2 positive breast cancer. It's over to you, ma'am.
Good evening, everyone. Thank you, Dr. R.K. Chaudhary, sir, and Roche, for giving this opportunity. So I would be sharing my screen. Is it visible?
Yes, ma'am.
Okay. So the impact of subcutaneous dual HER2 blockage on patients of HER2 positive breast cancer. Is my slide moving?
Yes, ma'am.
Okay, so the slide is shared by Roche, and now coming to the PAT-CR, so we will directly proceed. Just a second. So achieving a PAT-CR with neoadjuvant chemotherapy result in longer survival benefit. So as the CT-neo breast cancer a meta-analysis has shown that patient who have a PAT-CR as compared to the one who have a residual disease, there is an event-free survival benefit as well as some OS benefit has been seen. There are a number of studies, especially one study by Cortazar et al. In Lancet. It's a single center retrospective study. It was a real world evidence, and we have seen that there is some benefit in DFS as well as OS. So, neoadjuvant treatment with dual anti-HER2 plus chemotherapy results in a higher PAT-CR as compared to Herceptin plus chemotherapy. As we can see here, it is NOAA, HANA, and chemo plus pertuzumab, chemo plus per2 plus trastuzumab, and pertuzumab plus docetaxel. So what we have seen, the PAT-CR ranges between 38 to 39%. So when we don't add trastuzumab in a neoadjuvant setting in HER2 positive, the PAT-CR achieve is close to 15 to 20%. By the addition of Herceptin, by the addition of trastuzumab, our PAT-CR increases up to 40%, and after the addition of pertuzumab, as we can see in Trifina, Berians, Jepar-Octo, Jepar-Septo, TRAIN-2 and ADAPT trial, we can see the PAT-CR ranges between 60 to almost 90% in the latest trial, which is ADAPT. It's a trial of de-escalation of combination of chemotherapy, that is weekly Pacli for 12 cycle with Per2 and Trastuzumab versus Per2 and Trastuzumab alone without chemotherapy, and the PAT-CR with dual anti-HER2 plus paclitaxel reaches up to 90%. So,
Ma'am, please make it full screen.
yeah. So patient receiving neoadjuvant pertuzumab Herceptin have improved event-free survival. So what we can see, This is Herceptin, trastuzumab followed by trastuzumab. This is Per2, Trastu followed by Trastu, and this is dual followed by dual. That means in the neoadjuvant setting, we are using dual anti-HER2 followed by the same in the adjuvant setting. And what we see that patients without event increasing once we from trastuzumab to neoadjuvant pertuzumab plus trastuzumab up to 82% to the combination of dual anti-HER2 in neoadjuvant as well as adjuvant setting, it is up to 94%. So event-free survival rates in patient with PATCR by treatment modality. So we know that PATCR gives some event-free survival benefit, and this we can actually see here. And especially, this is a single agent anti-HER2 in neoadjuvant and adjuvant setting. This is pertuzumab plus trastuzumab followed by single agent trastuzumab, and this is dual anti-HER2 in neoadjuvant and adjuvant setting. And very well we can see the event-free survival rates are actually increasing up to 90 to 97% in dual anti-HER2 therapy in both neoadjuvant and adjuvant setting. So this is an event-free survival in patient with early HER2 positive breast cancer with PAT-CR after HER2 targeted therapy. So it is a pooled analysis, and again we can see that it is depicting the same thing that dual anti-HER2 in neoadjuvant and adjuvant leads to the hazard ratio of 0.36 as compared to 0.56 when we used a single agent anti-HER2 in adjuvant setting. So same is depicting in the patient who have a residual disease. Again, your hazards are 0.43 as compared to 0.60. So regardless of PATCR status, as we can see that this is PATCR and this is a residual disease. And in both we can see, so regardless of whether patient achieve PATCR or a patient has a residual disease, there is a benefit in terms of event-free survival, and which is greatest when we administer pertuzumab plus trastuzumab in both neoadjuvant as well as in adjuvant setting. So this is recent evidence on dual HER2 blockage from studies. This is Berenen's study. Now this Berenen's study is actually a cardiac safety study of neoadjuvant dual anti-HER2 with chemotherapy followed by adjuvant. So it was dual in both in the neoadjuvant as well as in adjuvant in HER2 positive early breast cancer. So we can see that there is not much major difference, and our cardiac events are actually comparable. But now coming to the PAT-CR rate, so patient who have a PAT-CR, as we can see, the event-free survival is better as compared to the patient who have a residual disease. So this is a phase 3 Peony trial, which is the trial of efficacy, safety, and tolerability of pertuzumab, Herceptin, and docetaxel for patient with early or locally advanced HER2 positive breast cancer in Asia. So as we can see, the event-free survival is 11% difference, and disease-free survival also there is an 11% difference. So the most common adverse effect, as we know, by the addition of pertuzumab is diarrhea, which was seen in dual anti-HER2 arm, which was to the tune of 40%. So EFS, DFS, and OS, they were all supportive of tumor PAT-CR, and it suggested a clinically meaningful improvement with dual anti-HER2 blockade. So what is the current status of dual anti-HER2 blockade? So this is an NC 2024 version, and we can see TCHP, that is anthracycline-free regimen in the pre-op as well as in adjuvant setting is category 1. If there is a no residual disease after pre-op therapy, which is PAT-CR, we can complete either Trastu plus minus pertuzumab. And if there's a residual disease, as we know, we treat patient with TDM1, which gives an 11% disease-free survival benefit. So in the systemic adjuvant therapy, so whether you are hormone receptor positive or negative, in HER2 positive, the trial supports adjuvant trastuzumab plus pertuzumab once the node is positive or the tumor size is more than 2 centimeters. So this is hormone receptor negative. Again, the adjuvant dual anti-HER2 is the standard. So again, now, as it was very well explained by the previous speaker regarding systemic therapy regimen for stage 4 M1 disease. So as we know, Cleopatra trial, TC, the PER2, TRAS2 and docetaxel regimen with a good PFS, OS and response rate. So now this is ESMO guideline for early breast cancer. So as we know, in T1, that is tumor size which is less than 2 centimeter, upfront patient can be operated. And once it is T1, we can offer patient APT regimen, which is adjuvant paclitaxel 12 weekly, followed by trastuzumab up to 1 year. Then any pathological stage PT2 node negative adjuvant chemotherapy with trastuzumab, followed by 1 year of maintenance. The moment it is node positive, we know it is dual anti-HER2 therapy. And in neoadjuvant setting, if the in the neoadjuvant setting, if patient is node positive or the tumor size is more than 2 centimeter, we can give 6 cycle of chemotherapy combination with dual anti-HER2 blockade. And after surgery, if it is a PAT CR and the patient had node negative at initial diagnosis, we can continue only trastuzumab. But if at initial staging it was a node positive, we have to complete 1 year of dual blockade with pertuzumab. And as we know, in the residual invasive disease, the standard is TDM1 up to 14 cycles. So, now we are very clear of the benefit of dual anti-HER2 in neoadjuvant, adjuvant, as well as in metastatic setting in terms of EFS, OS benefit. And in neoadjuvant setting, also there is a benefit of PAT-CR reaching up to 60%. And in the latest ADAPT trial, the PAT-CR ranges up to 90% with taxanes alone. So after this, what is the process of receiving IV therapy? So this process actually places a significant burden on entire life of HER2 positive breast cancer patient, because in addition to chemotherapy, we have to give 2 more IV infusion of dual anti-HER2 blockade. So that creates a logistic and time burden, physical pain and discomfort. And so this nature of burden faced by patients on IV treatment differs. So that depends like on what stage the patient are, their own life circumstances, what is the working distance, and also the what support is available to them in terms of financial and emotional support.
Ma'am,
Now
sorry to interrupt you. Can you please conclude your talk?
okay. So these logistic challenges create anxiety and frustration. So what we can see, the IV infusion of Perjeta. So as we know, pertuzumab is infused over 60 minutes and Herceptin over 90 minutes. So it has a preparation cost in dwelling venous axis and IV axis. So we have Phesgo, which is a combination of pertuzumab and Herceptin in a subcutaneous form. And Federica is a phase 3 trial which has actually shown there was no difference in terms of pharmacokinetic or PAT-CR. Even it has shown that the adverse effects were comparable, except the injection site reaction, which were more in Phesgo. And so all these are actually explaining the same thing. So it is also a cost-effective strategy because Roche is giving some patient assistance program, so that reduces the cost burden. So in a nutshell, neoadjuvant therapy with fixed dose combination, and we have seen that that even when we stratify patient by body weight and compare FDC versus IV infusion of dual anti-HER2, there is no difference in the outcomes and as well as adverse event. And it is a cost-effective strategy, particularly for the patient who are node positive, HER2 positive early breast cancer. So free from lines, far away from fear, since it is a subcutaneous dual anti-HER2 blockage. Thank you.
Thank you, ma'am, for wonderful talk. Next session is sponsored by AstraZeneca. For the next session, I would like to invite Dr. Sanjay Rai. Dr. Sanjay Rai.
Yeah.
Yes, yes, sir.
Am I audible?
Yeah.
Kindly share my slide, please.
Yes, sir.
Okay, I will speak on in HER2 for the treatment of HER2 low metastatic breast cancer. This is a new classification which has come up after that Destiny 04 trial. And I will speak on next slide, please. Introduction to HER2 low metastatic breast cancer, followed by what is the about an HER2 monoclonal antibody, then Destiny study design, Destiny efficacy, safety and quality applied data, dose modification, adverse effects management, and how to administer in HER2 and dosing consideration. Next slide, please. As we know that metastatic breast cancer, hereby it will be MBC, is a global problem, and 5-year survival of only 25% is reported at present. It continues to be a global issue and global challenge. Next, please. Next slide, please. Metastatic breast cancer is classified by HER2 expression, which is determined using two assays, immunohistochemistry and in situ hybridization test. And historically, there were two reports, either positive or negative. And for HER2 negative metastatic breast cancer, which constitute almost 85%, there were limited treatment options. And now after HER2, this Destiny trial, this if you see this 85% of the population of HER2 negative metastatic breast cancer, there was rapid decline after first, second, and third line of therapy in median progression-free survival. And they have limited options. And if you see in HER2 negative metastatic breast cancer, after progression, if it is hormone positive, after progression on endocrine therapy, median progression-free survival 16 to 28 months with endocrine-based options, but is only 6 months the subsequent chemotherapy. In hormone positive HER2 negative metastatic breast cancer, there is a greater than 50% drop in median progression-free survival after endocrine therapy is exhausted. For patient with hormone negative HER2 negative status, MBC, which are ineligible or have exhausted treatment, targeted treatment, chemotherapy is the only option, and median PFS is nearly 6 months with the first line option and decreases to 2 months with subsequent therapy. The treatment landscape is evolving and the need to identify additional targetable population, including HER2 low MBC, which has become critical. Next, please. HER2 low expressing MBC is found in nearly 50% of the population, and it is seen in both the situation, hormone positive and hormone negative. Next, please. Next, please. Destiny 04 trial establishes HER2-low as a targetable population, redefining the HER2 expression spectrum. Following these results, 50% of the patients with metastatic breast cancer who would have been classified as HER2 negative may be classified as HER2-low, and they may benefit from HER2-based therapy. HER2 is the first HER2-targeted therapy to demonstrate a statistically significant improvement in PFS and overall survival versus chemotherapy in patients with HER2-low metastatic breast cancer. Safety analysis of Destiny 04 trial in breast demonstrated a benefit-risk profile that was consistent with prior HER2-positive studies of in HER2. The most common any treatment emergent adverse effects in greater than 30% of the patients seen was nausea, fatigue, alopecia, vomiting, neutropenia, and anemia. Next, please. I will skip this regarding HER2 antibody. Previous speakers have already spoken. Go for next slide, please. Next. Further, next slide. Next. Okay, coming to Destiny 04, Breast 04 study design. It was a phase 3 international trial designed to evaluate HER2 in HER2-low metastatic breast cancer, which is represented as ISC1 plus or ISC2 plus when FIS is negative. This was an open-label randomized study comparing the efficacy and safety of HER2 versus treatment of physician choice of single-agent chemotherapy. The study included 2 cohorts. 494 was our hormone receptor positive patients and 63 were hormone receptor negative patients, which they say corresponds to real-world situation. The trial included a total of 557 adult patients who had unresectable or metastatic HER2-low breast cancer and tumor previously not classified as HER2 positive on any prior pathology testing, must have received chemotherapy in the metastatic setting or have developed disease recurrence during or within 6 months of completing adjuvant therapy. If hormone positive, must have received at least 1 endocrine therapy or be ineligible for endocrine therapy. No prior HER2 directed therapy was allowed. Patients were randomized into 2:1 to receive either HER2 5.4 milligram per kg. Total number of patients were 373 by IV infusion every 3 weeks or treatment of physician choice of single agent chemotherapy. Number of patients were 184. Chemotherapy options were capecitabine, eribulin if triple negative, gemcitabine, paclitaxel or nab-paclitaxel. Treatment was administered until disease progression, death, withdrawal of consent, or unacceptable toxicity. Randomization was stratified by HER2 IHC status, number of prior lines of chemotherapy in the metastatic setting, hormone receptor status with or without prior CDK4/6 inhibitor use. The primary endpoint of the study was progression-free survival in the hormone receptor positive population, as I said, assessed by BICR. The key secondary endpoint included PFS, assessed by BICR in the overall study population, overall survival in the hormone receptor positive population, and in overall population. So, key secondary endpoints were analyzed hierarchically. Secondary endpoints included investigator-assessed PFS and ORR, DORR, and efficacy in the hormone receptor negative population. Next, please. Baseline patient demographics and disease characteristic in Destiny Breast 04 trial were as follows. In the HER2 arm, the median age of patient was 58, range was 38 to 80, and 99.5% were female. In the chemotherapy arm, the median age of patient was 56, and all patients were female. Of the entire patient population, 48% of the patients were white, 40% were Asian, and 2% were black or African American, and 3.8% were Hispanic. 55% had an echo PS of 0, while the rest had echo PS of 1. 89% were HR positive, and 58% of the patient had ISC 1 plus. Next, please. Coming to disease characteristics, sites of metastasis at baseline were balanced between treatment arms. 70% of subjects had liver metastasis, 33% had lung metastasis, and 6% had brain metastasis. Next, please. Prior lines of therapy were generally balanced between treatment arms. Of all patients, 59% receiving Enhertu had one prior line of chemotherapy in the metastatic setting versus 54% receiving chemotherapy arm. Of all patients, 39% receiving Enhertu had two prior line of chemotherapy in the metastatic setting versus 45% receiving chemotherapy. Of the 494 hormone receptor positive subjects, 27% had greater than 3 prior line of endocrine therapy in the metastatic setting. 33% had 2, 31% had 1 line, 9% had no prior line of endocrine therapy. Additionally, 70% of the hormone receptor subjects were exposed to CDK4/6 inhibitors. The Enhertu hormone receptor positive arm, the median prior lines of endocrine therapy was 2, range from 0 to 7, and the median number of prior lines of systemic therapy in the metastatic setting was 3. Next, please. Next, please. Coming to efficacy data, here is the Kaplan-Meier estimate of median PFS in the Enhertu arm was almost double than the median PFS in the chemotherapy arm, the hormone receptor positive group, and in overall population as assessed by BICR in the there was a 49% reduction in the risk of disease progression or death with Enhertu versus chemotherapy. Median PFS was 10.1 months in the Enhertu arm versus 5.4 months in the chemotherapy arm. Enhertu significantly increases median overall survival by more than 6 months compared with chemotherapy, which was secondary endpoint actually. Here we have a Kaplan-Meier curve depicting probability of overall survival for patients receiving Enhertu or chemotherapy. Overall survival in the hormone receptor positive subgroup was one of the key secondary endpoint in the Destiny Breast 04 trial. There was 36% reduction in the risk of death with Enhertu versus chemotherapy, and median overall survival was 23.9 months in the Enhertu arm versus 17.5 months in the chemotherapy. The median follow-up period was 18.4 months. Next, please. Out of all pre-specified group, previous slide, please. Please go. Yes. Consistent with median PFS and overall results were reported in all patients with HER2 low MBC, apart from hormone positive patients when data was together analyzed. Here we have a Kaplan-Meier curve depicting probability of PFS for all patients receiving Enhertu or chemotherapy. There was 50% reduction in the risk of disease progression or death with Enhertu versus chemotherapy. Median PFS was 9.9 months in the Enhertu arm and 5.1 months in the chemotherapy arm. And in another curve, there is overall survival data for all patients. There was 36% reduction in the risk of death with Enhertu versus chemotherapy. Median overall survival was 23.4 months in the Enhertu group versus 16.8 months in the chemotherapy group. Next, please. So consistent progression-free survival benefit was observed with Enhertu in pre-specified exploratory patient subgroup. In hormone receptor positive, HER2 low MBC, pre-specified exploratory patient subgroups were not tested for statistical significance and not powered to show difference between treatment arms or between treatment subgroups. Next, please. In HER2 delivered almost nearly 53% of response rate, more than triple the response with chemotherapy in the hormone receptor positive HER2 low metastatic breast cancer. And overall response COR was an additional secondary endpoint in the Destiny 04 study. In the hormone receptor positive population, COR for NHER2 was 52.6% and 16.3% for chemotherapy. 49.2% of patients experienced partial response rate with NHER2 and 15.7% with chemotherapy. Disease control rate was 88% for NHER2 and 66.3% for chemotherapy. The CBR combined response rate was around 71.2% with NHER2 and 34.3% with chemotherapy. Median duration of response was 10.7 months with NHER2 and 6.8 months with chemotherapy. ORR and DOR were not tested for statistical analysis and were not powered to show difference between treatment arms. Next, please. The majority of patients who received NHER2 experienced a reduction in tumor size. Next, please. Efficacy of NHER2 was also reported in hormone receptor negative population and demonstrating consistent positive outcomes in hormone receptor negative population as descriptive and were not tested for statistical significance nor powered to show a difference between treatment arms. ORR and median duration of response were not tested for statistical significance and were not powered to show difference between treatment arm in hormone receptor negative population. Next, please. The next piece coming to safety data, Destiny 04 helped to establish the NHER2 safety profile in HER2 low MBC. The majority of adverse reactions were grade 1 and 2. The most common adverse events reported in NHER2 arm were nausea 73%, fatigue 48%, skinniness, subcutaneous tissue disorder, alopecia 38%, vomiting 34%, neutropenia 33%, and anemia 33%. Prophylactic or supportive treatment for expected toxicities, including management of study drug adverse effects, was conducted as per investigator discretion and institutional guideline. The median duration of treatment was 8.2 months for patients who received NHER2 and 3.5 months for patients who received chemotherapy. Next, please. Treatment-related adverse reactions may require dose modifications, and 23% of patients treated with NHER2 experienced dose reduction due to adverse reaction and 38% with chemotherapy. Dose interruptions due to treatment emergent adverse effects occurred in 39% of patients treated with NHER2 and 42% with chemotherapy. Discontinuation of treatment due to adverse reactions occurred in 16% of patients treated with NHER2 and 8% with chemotherapy. For NHER2, the most frequent treatment emergent adverse event associated with discontinuation was ILD pneumonitis, which was seen in 8.2% of the patients. And as per protocol, NHER2 was discontinued in Destiny 04 breast trial in patients who were diagnosed with any symptomatic grade 2 or higher ILD. Next, please. So ILD or pneumonitis, including grade 5 cases, were reported in Destiny breast 04 trial. The majority were grade 1 and grade 2. Of the 371 patients treated with NHER2, 5.4 milligram per kg in Destiny 04 ILD occurred in 12.1% of patients. 3 grade 5 adjudicated drug-related ILD events were observed with NHER2. 82% of the ILD cases were grade 1 and 2. In Destiny 04 trial, median time to onset of first adjudicated drug-related ILD event was 129 days with NHER2. Next, please. Coming to quality of life data, next. In Destiny Breast 04, GHS quality of life was maintained by NR2 and chemotherapy as measured by median change from baseline, UOTC, QLQ, C30 score. Fatigue, nausea, and vomiting are adverse reactions that are frequently reported by patients on NR2 treatment. Patients who received NR2 reported worse nausea and vomiting compared to patients who received chemotherapy. In the NR2 treatment arm, the increase in nausea and vomiting scores was only clinically relevant in early cycle, after which scores decreased and remained stable over time. Within 10 points of baseline from cycles 7 to cycle 27, indicating no
Sir,
significant
sorry to interrupt you. Can you please conclude your talk?
dosing and administration. It was 5.4 milligram per kg every 3 weeks, and till discontinuation or acceptable toxicity or progression of the disease. And then okay, I will conclude here only because I have covered most of the toxicity. Thank you very much.
Thank you, sir, for wonderful talk. Next session is sponsored by AstraZeneca. For next talk, I would like to invite Dr. R.K. Chaudhary. He will give his talk on evolving trends in HER2 positive metastatic breast cancer. It's over to you, sir.
Thank you, Nishant. Can you please share my slides?
Yes, sir. Give me 1 minute.
Okay, good evening once again. So, am I audible?
Sir, audible.
Right. So, thank you, Astra for thank you, AstraZeneca, for providing me the slides. And this is sponsored session by the AstraZeneca. And topic for my talk is evolving trends in management of the HER2 positive breast cancer, specifically the metastatic. There have been a few talks previous also, specifically by Dr. Sajjan, where he talked about the same topic. So I'll be discussing more of a newer molecule, which is TDXD1. What's the role, where we can fit it, and what are the other options? So move on to next slide, please. So outline of today's presentation is like introduction. So what is the HER2 positive MBC? Then what are the unmet med for second line and beyond in HER2 positive breast cancer? Recent advances in HER2 positive MBC. So I'll be discussing about the trastuzumab deruxtecan, that is TDXD, neratinib, and tucatinib. One trial each for these drugs. Then current treatment algorithm for HER2 positive MBCs. Then I'll conclude my talk with the take-home message. Next slide, please. Next, please. So talking about the introduction to HER2 positive breast cancer, we know this is an aggressive form of breast cancer, which is most frequently diagnosed cancer. Breast cancer is one of the most frequently diagnosed cancer, and it is the leading cause of cancer-related deaths among women worldwide. Approximately 30% of all breast cancer cases will become metastatic after the diagnosis, and most breast cancer deaths are due to metastatic disease. HER2 positive breast cancer cells are associated with aggressive disease that are more likely to metastasize. 15 to 20% of all the invasive breast cancer cases are HER2 positive, which is defined by either IHC 3 plus positive or by FISH, where HER2 gene amplification is seen. Next slide, please. So molecules, go back to the previous slide, please. So breast cancer subtypes by the hormone receptor and HER2 receptor status. Around 20.7% of the patients are HER2 new positive. Out of those, 7.4% of patients are hormone negative HER2 positive, and 13.3% of the patients are hormone positive and HER2 positive, that is triple positive. Hormone positive and HER2 negative breast cancer are the largest number of patients, which are around 65 to 70% of patients, and 13.3% of the patients are triple negative patient in reported by this particular study. Next slide, please. So few discoveries have shaken the foundation of cancer treatment, like discovery of human epidermal growth factor. It has been the treatment or practice changing discovery. A few lines about the HER2. Oncogene HER2 overexpression confers an aggressive tumor behavior, but also an opportunity to targeted therapy. Next slide, please. Coming to the unmet need for the HER2 positive breast cancer, we know in the first line treatment in HER2 positive cancer, we have the very good drug, which is in the form of trastuzumab. But when it comes to the progression after the trastuzumab, there are many players. But now we know there is a clear winner. So as HER2 targeted treatment options continue to expand, physician will weigh many factors when sequencing the treatment. More than 1/3 of the patient will not receive subsequent therapy after the second line treatment, which is a huge chunk of patient and may miss the opportunity to receive the highly effective HER2 targeted as an if it is not prioritized for the early use. So 78% of the patient will receive the second line therapy. That means 22% of patient will not receive the second line of therapy. And after the second progression on the second line of treatment, around 35% of the patient do not receive third line therapy. Therefore, the sequencing decision depend on the previously administered therapies, progression-free intervals, site of progression, tumor burden, patient preference, and quality of life. And of course, the availability of the drugs. Next slide, please. So key data supporting the existing therapy in metastatic breast cancer are first line treatment. It was studied in Cleopatra with the 808 patients were studied, and drug combination regimen used was the THB and comparator was the TH, which was the standard of care at that time. Overall response rate was 80% in 3-drug triplet versus 69% in doublet. There was the delta of 6.3 months in median PFS and delta of 16.3 months in the median overall survival. Common treatment associated adverse effects were diarrhea, alopecia, neutropenia, nausea, fatigue, rash, decreased appetite, mucosal inflammation, asthenia, and peripheral edema. Grade 3 and more than 3 adverse effects was more or less similar, 2% higher in the triplet versus doublet. Next slide, please. In the second line therapy, Amelia study was there with that. The study that TDM1 with the then standard of care, lapatinib with capecitabine, and overall response rate was 44% with TDM1 versus 31% in the standard of care, lapatinib with the capecitabine. Median PFS gain of delta of 3.2 months was gained with the TDM, and coming to the median overall survival, 30.9 months with the TDM versus 25.1 months with the lapatinib with capecitabine. Common side effects were diarrhea, fatigue, nausea, elevated AST, thrombocytopenia, and these were 16% higher in comparator group. Next slide, please. So median PFS drops by approximately half numerically, moving from the first line treatment with the THP to the second line treatment with TDM1. In Cleopatra, median PFS was 18.5 months, and in Amelia, median PFS was 9.6. So there was numerical fall of 50% in the second line treatment. We also know that Cleopatra and Amelia were conducted simultaneously. So year of study population were 2002 in Cleopatra THP and 2017 to present day in. From 2017 to present day, there were real world evidences of studies on the second line TDM1 following the pertuzumab. Because at that time, pertuzumab was not approved. So in Amelia, there was no prior exposure to the pertuzumab. So second line TDM was not evaluated in patient with prior pertuzumab in this particular Amelia trial. Outcome for the first line THP followed by second line TDM1 sequence have not been reported from the randomized clinical trial. However, the available data are limited to real-world evidences and have shown reduced efficacy with TDM1 following the pertuzumab in the first line. Next slide, please. So evidence suggests that PFS outcome for the second line TDM1 are worse when patient who received a prior pertuzumab. So trastuzumab, pertuzumab followed by TDM1, two large real-world Italian studies evaluated second-line TDM1 from the pertuzumab exposed versus naive population and reported significantly worse median PFS outcome and conflict OS results, with one study reporting a worse OS and the other with a similar OS. Next slide, please. So reduced outcome with TDM1 after the prior pertuzumab may be due to reduced HER2 expression. Resistant to pertuzumab and trastuzumab may lead to reduced HER2 expression and reduced TDM activity. DM has limited permeability and is unlikely to impact the tumor cells beyond HER2 positive, what we call as bystander effect. So further supporting the impact of HER2 expression on the TDM1 effectiveness are data from the post-hoc analysis of the marine trial. Patient with heterogeneous versus homogeneous HER2 expression achieved a shorter median PFS with first-line TDM1. Next slide, please. So what are the recent advances in HER2 positive MBCs? So there are three or four drugs, like TDX1, then tyrosine kinase inhibitor, neratinib and tucatinib, and margetuximab. Next slide, please. So there have been unprecedented flourishing of the anti-HER2 pipelines, and as many as 8 anti-HER2 drugs currently authorized by the US FDA in MBC, and half of these drugs are approved in the time frame of one single year. From 2019 to 2020, TDX1, neratinib, tucatinib, and margetuximab were approved by the US FDA for MBC, HER2 positive MBC. Next slide, please. Coming to the TDX1, next slide, please. This is the mechanism of the trastuzumab deruxtecan. We know that this is a drug antibody conjugate, ADC, and there are three components. One is the payload, which is highly potent topoisomerase 1 inhibitor. Then there is a antibody, which is transporter and cleavable linker. Here in the TDX, 8:1 drug to antibody ratio is there. So internalization of TDXD leads to release of the TXD payload and subsequent cell death in the target tumor cells and also in the neighboring tumor cells through the bystander effect. This is the mechanism of action. This is the cell membrane. There is internalization, binding of the TDX to the HER2 receptor, then internalization, then linker is cleaved, releasing the topoisomerase 1 inhibitor, which is translocated into the nucleus, causing the tumor cell death. Then there is a member permeability, which payloads of the permeable payload, resulting into bystander effect, killing of the neighboring cells. So TDXD demonstrated response to therapy in 60.9% of the pre-treated patient population with HER2 positive metastatic breast cancer. Next slide, please. Sorry. Coming to Destiny Breast 02 trial, which is a randomized phase 3 open label multi-center study. Key eligibility criteria for the Breast and Destiny Breast 2 trial were centrally confirmed HER2 positive either by IHC3+ or IHC2 positive and FISH positive. Unresectable or metastatic breast cancer documented radiographic progression after most recent treatment, previously treated with TDM1. Stratification factors were hormone receptor status, prior treatment with pertuzumab, history of visceral metastasis. TDXD was used in the dose of 5.4 milligram per kg every 3 weekly. Number of patients included in this arm were 406. In the physician treatment choice, many drugs were used like trastuzumab, capecitabine, lapatinib plus capecitabine combination. Primary endpoint was with PFS. Key secondary endpoints were overall survival. Secondary endpoints were overall response rate reviewed by the Central Review Committee. Duration of response, PFS, and exploratory endpoints were as clinical benefit rates and PFS2. Data cut off June 30, 2020, the median duration of follow-up was 21.5 months in the TDXD arm and 18.6 months in the TPC arm. Primary analysis planned for 372 patients, PFS events observed in 18 months from the last patient randomized, whichever came first. Next slide, please. Go back to previous slide. Yeah. So this is the PFS data by Central Review Committee, and we can see there was huge gap in the Kaplan-Meier curves. At the 12 months, PFS was 60. Median PFS rate was 62.3% in the TDXT arm versus 27.2 in the TPC arm. And coming the median PFS in months, 17.8 months with the TDXD versus 6.9 month, almost 3 times more in the TDXD arms. Next, please. OS benefit was also seen at 12 months. OS benefit
Sir,
with
sorry to interrupt you. Can you please conclude your talk?
Right, I'll try to. So in TPC form, 69.3% of the patient who discontinued therapy received a new systemic treatment, and 25.7% of the patient received TDXD in the post-trial set. Next, please. So I'll conclude the Destiny Breast 02 trial. This demonstrated significant and clinically meaningful improvement in PFS and OS with versus TPC in patients with HER2 positive MBC previously treated TDM1. And overall safety profile was consistent with the stabilized safety of TDXD with no new safety signals observed. Next slide, please. I'll touch upon the one trial for each. I'll skip the Destiny 03 trial. Next slide, please. One slide each for the tucatinib and neratinib. Next, please. Straightforward, come to the tucatinib. Next. Next. Next, please. Next, please. Next. Next, please. Go on, go on, go on. Go on. So to get next, please. Just go back. One slide. Next, please. This is your scheme of all the slides. So one slide would the took. Can you go back to three slides back? One more. Just next. Next, please. So no, you're missing the slides. Right, straight on this slide. So this is a HER2 CLIMB trial adding the tucatinib to trastuzumab and capecitabine resulted in a better progression-free survival. And we can see there is a median PF of overall response rate of 41% with addition of the tucatinib versus 23% in the tucatinib trastuzumab plus capecitabine triplet versus doublet. And a median PFS of 7.8 months was achieved versus 4.91, and median overall survival was 21.9 months in triplet versus 17.4 months with the doublet. These were the common side effects: diarrhea, PP syndrome, nausea, vomiting, decreased appetite, stomatitis, headache, and so on. Next slide, please. Next. Hold on this. So this was the NALA trial of the neratinib plus capecitabine versus standard of the care lapatinib plus capecitabine. And here again, their overall response rate was 33% with the neratinib versus 27%, and median PFS was improved with 8.8 months versus 6.6 months. However, there was no difference in the overall survival, 24.0 versus 22.2% months. Next slide, please. So go back, go to the concluding slide. Next, please. Next. One slide back. Okay. Next. Okay. So take home message is between the Take home message is between the first line THB and second line TDM1 treatment, the median PFS drops numerically by half, demonstrating that more effective treatment options that further delay the progression and extend survival are needed in the second line. The current treatment paradigm of HER2 positive advanced breast cancer include THB followed by the TDXD after progression as a standard of care for initial treatment with multiple third line options including neratinib, tucatinib, TDM1 and margetuximab are now available. However, the optimal sequencing for third line setting is still not clear, and in a time to come, we'll be able to sequence these drugs also. Thank you. Thank you so much for patient hearing, and thank you once again for Astra for providing me the slides.
Thank you, sir. For the next talk, I would like to invite Dr. Ankur Ponia. He is the Assistant Professor, Department of Medical Oncology, Mahatma Gandhi University of Medical Sciences and Technology at Jaipur. He will give his talk on selection and sequencing of therapy for patients with metastatic triple-negative breast cancer. It's over to you, sir.
Yeah, good evening, everybody. Just please share the slides.
Okay, sir, just give me.
So yeah, the topic to discuss is lastly after all the HER2 talk is how to select and sequence the therapy for metastatic TNBC patients. Next slide. Now we have multiple options. Usually the first line option for these patients with metastatic TNBC is based on the PDL1 and whether they have BRCA mutated or not. So patient is PDL1 positive, ideally we give either chemotherapy with pembrolizumab is considered the best option. If patient is PDL1 negative, BRCA also wild type, then just chemotherapy. If patient is yes BRCA mutated, then we can give the option of giving patient PARP inhibitor. So second line, if patient can take sacituzumab govitecan is a good option for these patients. For patient who have not received PARP inhibitor in first line, they can be given, and eventually whatever they have not received in the first line or in the second line can be given in the third line to these patients, which is usually chemotherapy, or for HER2 low patients, we have the option of now TDXD as well. Next slide. So for pembrolizumab Keynote 355 study, the main study, we can see that patient for whom the PDL1 CPS was more than 10%, there was 6.9-month increase in OS. It was 23 versus 16.1 month, which was statistically significant. So based on this, and this become a standard of care for PDL1 positive patients. Next slide. And this is the recent study which was presented in this year, I think, ASCO. I am patient 132. It took the patients who are very early relapsing, sort of relapse within less than 12 months of receiving completing their treatment for the early breast cancer. But this trial failed to show any benefit even for PDL1 positive or overall intention to treat population. So maybe these patients don't do well with the addition of atezolizumab in this study. Next slide. Regarding the use of PARP inhibitor, we have the Olympiad study, basically took patients and randomized them to olaparib versus chemotherapy, showed improvement in PFS. Similarly, there is a BRCA study which compared talazoparib and again showed more or less the same PFS benefit of around 2 to 3 months in improvement in the PFS. So based on this, the PARP inhibitors can be used in the first line or even the second line setting. Next slide. So this slide highlights particularly the patients who have taken this PARP inhibitor in the first line setting, and we can see there's a clear-cut benefit. OS was 22.6 versus 14.7 months, and at 4 months, around 25% of patients were alive with PARP inhibitors. Next slide. So now the upcoming thing, which is more important in TNBCs, are the ADCs. Now multiple ADCs are coming up. Sacituzumab govitecan has been approved. We have TDXT also approved, but multiple others like depatupumab and paritumab and letrozumab are also in development. We look at them one by one. Next slide. So secukinumab govitecan is basically anti-TROP2 ADC, uh, and it has been tried in earlier line setting and showed a good response even in patients who were multiple treated with median 4 lines of therapy. They had a PFS of 4.8 months. So based on this, it's now approved in the second line setting. Next slide. So now what now has been done is we are trying combinations as well, though we have not access to secukinumab govitecan directly. But then now people are trying combining this with the immunotherapy. So this was a poor Morpheus Pan BC breast cancer trial. In the first line setting, patients, so advanced metastatic setting patients were taken, and its primary endpoint was overall response rate, which was around 76.7, which is remarkable for TNBC patients. And this study is going on, but it gives us some idea that yes, immunotherapy and ADCs can be combined. Next slide. So this showed that for patient who received this combination, had a PFS of 12.2 months versus patients who received chemo plus immunotherapy combination, it was 5.9 months. Similarly, depth of response was almost double combining ADC rather than giving chemotherapy to these patients along with immuno. Next slide. So this shows more or less that almost all the patients responded. There was some sort of response, except one or two patients. Everybody responded. As I already told you, for PDL1 positive patient response rate for 76.7%. Next slide. So based on this, multiple now phase 3 studies have started, SECI-IO, in which they have combined secukinumab with pembrolizumab in first line setting in TNBC as well as hormone positive. Similarly, Ascent study 3 and 4, both are doing things slightly differently. SN3 is basically for PDL1 negative, SN4 is for basically PDL1 positive TNBC patients. Next slide. So Destiny 04 study, HER2 low, as was discussed earlier, for patients who were hormone negative or basically TNBC, it still showed a benefit, not that much, but still there is a PFS benefit of around 5 to 6 months. It was 8.5 versus 2.9 months. So again, it's a good option. Has become a good option for the patients with HER2 low and now even HER2 ultra low as well. Next slide. So drug-related adverse events most commonly are seen, which is nausea and majorly are hematological. ILD, yes, it's a concern, but very few grade 3 adverse events are there. Only 1.3 in this study. Next slide. So next thing which is coming up is the datopotamab deruxtecan. Again, it's anti-TROP2 and antibody. Next slide. It has shown a very good results in the early setting. You can again see the response rates are very high in heavily pretreated patients, and even 10% patients have received prior secukinumab as well. So it showed a good response rates in these patients around 30-35%. Next slide. So again, as was with secukinumab, again this was also combined with durvalumab in first line setting, and it showed more or less the same response rates of around 80% in the first line setting, that almost all the patients responding. Next slide. So based on this, now these tropion studies, which are basically for datopotamab, are going on in all kind of settings, in the early line setting, in the metastatic setting as well. So this will, might add one more drug to our armamentarium to use for this difficult to treat subgroup. Next slide. So this is one more molecule which was recently presented, secukinumab tirumetican, for patients who were, multiply treated TNBC. Next slide. This again showed the PFS benefit by independent committee review. It was 7 versus 2.5 months. So yes, ADCs are showing a good response much better than what we are seeing with chemotherapy. So they are the next big thing which might be happening in the TNBC scenario. Next slide. Interim OS, though not use interim analysis of the OS, but it was not reached in the secukinumab tirumetican arm. Next slide. Adverse event, nothing new was seen, which has been seen already with the other TROP2 inhibitors, and nothing new was seen in this study. Next slide. Another thing which is coming up is paritumab deruxtecan, basically targeting HER3. HER3 low is there in some patients. HER3 expression is there in TNBC patients, and there is a response rate of around 23% in the early dose finding studies of this drug. Next slide. So to basically conclude my talk, now we are coming up with more and more ADCs. So we have to know how when to use which ADC, whether we can use first ADC and whether the second, third, and subsequent line the other ADC will work or not. So now trials have started evaluating the sequencing of the whatever three ADCs which we have now, we have and are almost working in this scenario is secukinumab, datopotamab, and trastuzumab deruxtecan. So these will further tell us whether what kind of ADCs to use first if we can, and how to properly sequence these drugs. Thank you.
Thank you, sir. For the vote of thanks and closing remark, I would like to invite Dr. R.K. Chaudhary, sir. Sir, please.
Right, thank you so much, all the speakers, delegates, and all the Arma. I would like to thank you, Dr. Anuradha, Dr. Shyam Agarwal, Dr. Mohit Agarwal, Dr. Sajjan Raj Purohit, Dr. Pooja Babbar, Dr. Sanjay Rai, Dr. Ankur Pinya for taking out the time from their busy clinical practice and delivering nice talks. And we discussed today about the breast cancer, starting from the like molecular classification, then went on to the immunotherapy, role of immunotherapy and ADC. We also discussed about what are the options and sequencing for the HER2 positive, and also about the triple negative cancer. In the lung cancer, we started again from the molecular biomarkers. Then Dr. Shyam Agarwal gave a very beautiful talk about the ADCs and upcoming ADCs in the pipeline. We also discussed various subcategories of the lung cancer, coming role of ADCs and immunotherapies. And before I conclude, I would like to thank my academic partners, specifically Roche, AstraZeneca, Fresenius Kabi, Lupin Oncology, Cipla Oncology, Johnson and Johnson Intense Oncology, Dr. Reddy, Shamath Life Sciences, and their all entire team for unwavering support at all the events. Thank you once again. I would also like to thank you, event management, Mr. Tarun and his team, and our entire Horizon Conference team for managing such a smooth management of this day one Metrocon. Thank you,
sir.
once again.
Thank you, sir.
all
Thank
the
you so
friends.
much. Thank you
See
everyone
you
for
tomorrow
joining.
at the same at 7 p.m. for the day 2 Metrocon. Thank you.
Yes, sir.
Thank you, sir. Thank you everyone for joining. Thanks to my colleague Nishant and Swarangi. Thank you everyone. Good night, everyone.
Good night. Good night.
Support team. Thank you, support team. Close the meeting now.
Right.